छोड़ो ना, मोबाइल से ही कर लेते हैं। छोड़ो, अब लैपटॉप नहीं स्टार्ट।
Dr. Prabhat, are you ready?
Sir, perhaps forward you email.
We forward my email.
Rukuro bhai, you are running 3 minutes late.
Niro, we are live now.
Yes, sir. We're good to go.
Okay.
Just 1 minute.
So, good evening, everyone. Welcome to this Rssdi case files new episode, and that is related to another interesting case of maternally inherited diabetes. And we have got three eminent panelists, including endocrinologist, diabetologist, neurologist, and a professor of medicine from Agra who will be presenting the case. So first, I will request Dr. N.K. Singh to welcome everyone and introduce the faculties.
Today I have great pleasure in welcoming very eminent personality like Dr. A.K. Singh, which I think he is very much aware about the case we are going to present. I think he needs hardly any introduction to our Rssdi group. For others who are joined, for them he is a consultant endocrinologist at JD Hospital Diabetes Institute at Kolkata. Most important, he is also editor of the William Textbook of Endocrinology of the South Asian edition. He is executive editor of many journals, associate editor of Diabetes and Metabolic Syndrome. Everyone is aware that it is a very high impact journal. And he has, I think, endless orations, and I think he is the man of meta-analysis in India, from the India. So great pleasure in to welcome Dr. A.K. Singh.
I think he is the master blaster of Indian medical research. That is what we can tell.
In one line,
Legend.
Yeah.
Living legend.
Man. And our second panelist is Dr. Sanjeev Phatak. I think ex-president of API Ahmedabad, visiting diabetologist at the Sterling Hospital and SAL Hospital at Ahmedabad, and doctor of Juvenile Diabetes Association Ahmedabad. He has many publications to his credit. He is also at present the joint secretary in Gujarat Diabetic Association, and he has conducted many clinical trials and the first diabetologist in India to start insulin pump therapy. So with this credit, pleasure to again welcome him. And next our panelist is Dr. Salim Saab. He is the associate professor of neurology at the SDPIMR hospital at Ahmedabad, consultant neurologist, honorary to the governor of Gujarat. I think it tells the credit he has got, and the DM neurology from the SGPGI Lucknow, and a special training in epilepsy at Queen's Square, London. So I think because today's case also had some neurological things, so that's why we have also invited him. With that, today's presenter, Dr. Prabhat Agarwal. Nirav, can you display the CV slides of? Yeah. So he's a MD, FRCP Glasgow, and a postgraduate diploma of diabetes from the London, and fellow of Diabetes India, and many other things. He is a professor of medicine at SN Medical College, Agra. With that, to the flow of the events will be like that. He will present the case, and after the presenting the history, we will stop, and then we will discuss, and then we will proceed again and again. So, Dr. Prabhat Agarwal, you can start your presentation.
Sir, can you share?
Yeah, I cannot share it. I have.
So because from my side, videos is.
You cannot share.
Dr. N.K. Singh, if it is with you, then please try to share. Otherwise, you send to RX events. Okay.
No, he has
started.
He has started.
So by the time Prabhat starts sharing his screen, I will request everyone to keep their audio on mute. All the coordinators who are joining, who are joining from all the states, we welcome you all to this episode of Rssdi case files, and we look forward to your support in future episodes so that we can enroll more and more people for this interactive case discussion. But request all of you to keep your audio on mute. Over to you, Dr. Prabhat.
Just 1 minute, sir.
Yeah, you can, your screen is visual, you can do that. RF event, can you give your mail? I can, if possible, I can forward it. Because in my computer also, I'm not able to get it.
Sir, I will put my mail ID in the chat box.
Dr. Prabhat, can you share the mails? Or do you have the PPT now available?
I have PPT in my, sir, email.
Yeah, now you can just start it. Okay, fine.
It is.
Yeah, just say,
Visible, sir.
yeah, just start the slide so.
हाँ प्रभात, आज के जमाने में ये सब तो जानना होगा भैया.
Yeah.
Yeah. So good evening, respected seniors and colleagues. Sorry for the technical glitches. Today, I'm very honored and happy to share a wonderful case in the before all the stalwarts of the medicine. So this was a gentleman who was a known case of diabetic. He was a 25-year-old male. This male presented to our Indore. He is a known case of diabetes and GTCS. He was in disoriented state. According to history and the examination at that time, he was diagnosed as a case of the diabetic ketoacidosis. We shifted from emergency to the ICU, managed conservatively as per the protocols of the management of the diabetic ketoacidosis with the help of the insulin, diabetic fluids. He started improving after 1 day and he improved finally from the decay after 2 days. But as he regains consciousness, he started complaining of the poor vision and the hearing. Initially, we ignored it. We ensured it will be improved with the time. His father also stated that he is taking anti-epileptic drugs, and as he having the history of the GTCS since childhood, and on checking the medication, he was on the levetiracetam and the sodium valproate. With the time, his impaired vision and hearing started improving after 1 week and completely improved after the 20 days. After 20 days, he was become all right in terms of the vision and the hearing loss. According to his father, he was diagnosed as a case of diabetes almost 4 years ago. Currently, he is on glimepiride metformin combination. Glimepiride was 2 mg daily and metformin was 500 mg daily. According to his father, blood sugar was never controlled. He asked always sugars are more than 300, 400. When we advised HbA1c, current HbA1c at that time was 12.6. But one thing his father told us that whenever blood sugar is very high, more than 300 or 350, he always starts complaining of impaired vision and hearing. And as soon as the blood sugar becomes controlled, these problems with the time within a week or 2 weeks, these problems become normal. We took family history, and when patient becomes stable, his father told that her mother is diabetic since the age of 23 years. She was managed on OHA. She also complained of the hearing impairment, and she expired at the age of 29 years. So currently, her mother is not there. She expired at the age of 29 years. There was no records available with the patients, but as father stated that her blood sugar was never controlled. Whenever he go to the physician or the doctor, he took the tablets. He doesn't recognize the tablet. He doesn't know the tablet's name. But he told that whenever sugar is always high, sugar never becomes controlled. She also have one younger sister. She was also diagnosed as a case of diabetes at the age of 18 years. She also complaining of the hearing impairment, but she expired at the age of 20 years just after the diagnosis of the diabetes. 2 years later, he expired. Some acute complication of diabetes. His father don't know what was the complication, but he said that she was admitted at the remote hospital in the Firozabad near to the Agra, and she expired within a 14 hours after the just admission. He don't know what was the reason of the cause of death. When we further asked about the history, his maternal grandmother, that is a Naniji, was also diabetes, and she was diagnosed at the age of 40 years. and she expired at the age of 58. So she was almost was diabetic almost 18 years. He had two maternal uncles, that is Mamaji. Both were diagnosed diabetic at the age of 20 and 20 years respectively, and both had impaired in the hearing also. But their impaired hearing was not very crucial. When we asked, they said they were having the hearing impairment. Otherwise, they didn't mention from their self. His elder maternal uncle, that is Bade Mamaji, was expired at the age of 26 years. One maternal uncle is still alive. He's on some oral hypoglycemics. We requested so many times to bring his Bade Mamaji or the one mama, but he never bring, because he was living somewhere in the this Gujarat state. She also had one Mosi, that is a mother sister, but she was not tested diabetes till her expiry, and she was expired at the age of 24 years due to some postpartum complications. She delivered a baby. That baby is there, but her Mosi was expired at the age of 24 years. From the paternal side, his father is not diabetic, not having any family history of the diabetes. His father married to a new woman after the expiry of her mother, but she's till now he had no baby after the marriage from the second wife. And his maternal grandfather, means Nanaji, is also not diabetic, and he is still alive, healthy. I examined also Nanaji because his Nanaji came to my clinic also. So this is a pedigree analysis. On the left side, you can see there is a index case. Is in the three colored one box. You can see in the three color, one is a red. Red depicts diabetes. Green impaired vision loss, and the blue one is for the impaired hearing. Here you can see our patient index case. This man is a Jain, also having the GTCS. On the other side, there's her sister. She was having diabetes. She also have a impaired hearing, but she did not have having vision loss. Her mother, which was having the diabetes and also the impaired hearing, she again was not having vision loss, but she expired at the age of 29 years. As you can see, his father is not diabetic. One of Mosiji, on the white circle you can see, is her Mosi. She was expired due to postpartum complication. You can see in the square, two Mamajis. One is, both are diabetic, as you can see in the red one, and blue one is for the impaired hearing. One Mamaji was expired at the age of 25 years, just after the diagnosis of diabetes, 2 years. On the top, you can see his Nanaji is okay in the white square, and the circle one is having Nani having diabetes and impaired hearing, but she expired at the age of 58 years. So this is the pedigree of the patient.
Yeah, Dr. Prabhat, I will just stop here. So at this point of time, what you told to us that a 27-year-old this patient you presented to UOPD, and he had with history of 8 to 9 years of this GTCS. That's okay.
Yes, sir.
And
Yes,
there
sir.
was a history of sudden episode of hearing loss and vision loss.
Yes.
And he had one sister, also diabetic, 1 year ago due to, I think, expired. The sister was also diabetic 1 year ago. Yeah, and mother also had diabetes.
Yes,
but expired at the age of 23rd, you told. And both maternal uncle have diabetes and hearing problems. So,
yes, sir.
So now the first question is here. Dr. Sanjeev Phatak, can you tell what sort of diabetes you think? Is it type 1, type 2, or what else? Dr. Sanjeev.
Yes. So the patient presented with diabetic ketoacidosis. So immediately we would have to treat it as a patient with insulin deficiency. So at that time, you have to treat ketoacidosis first. Thereafter, looking at the family history and absence of ketosis for so many years, one can think about the other types of diabetes. And here you can see the strong family history, maternal side, definitely points us towards the diagnosis of genetic or some hereditary condition which has led to diabetes. Along with deafness, diabetes and deafness, we have seen cases of dead mode. We have also seen one case of the thing which we are going to discuss here. But obviously, that diagnosis is not very common, and that's why it will come to mind only if you have seen such cases. Otherwise, you are likely to miss it and will stamp it as type 1 diabetes because it presented with ketoacidosis.
Now, my next question is with Dr. A.K. Singh. Do you see that the history has been taken very nicely, or anything we were missing in the history?
Well, so let me start with the comments on this pedigree analysis, and for all of you listening to me. So first of all, let me point out two important points. First, if you look at this pedigree chart, so in the extreme right corner is the patient. What you can see, the green color, coding with vision loss is only lying with the index case. Now, if you go up in the ladder of this pedigree chart, one thing which is pretty common is the red colored mark, which is diabetes, and the blue colored, which is impaired hearing. And if you closely notice here that if you go at the top, means the patient's maternal, Nani ji, means grand maternal mother. Now, everyone here in this pedigree chart, the female is, inflicted with the disease. So there's no problem with the square, means male, on the first case. First is started with the, great grandmother of patient, as you can see, maternal grandmother of the patient, the female. And then if you come to the next generation, she has got 4 kids, of which 2 was male, 2 was female. Both the male was infected with the same disease. Out of that, one female, of the 2 female child she had, the one female had got the same problem. Now, if she got married to a normal person who didn't have diabetes or impaired hearing, and they have got 2 kids, of which one was female, one was male, both siblings had similar disease. Now, what was the mistake in this particular pedigree chart? Number one, although I was the co-author of this particular paper, then now I'm realizing what was the mistake we made. So in any pedigree chart, if you make a pedigree chart, those who died, you need to mark a cross line in a diagonal manner, means they are no longer alive. So this is what we missed in this pedigree analysis. I'm surprised even reviewer did not notice it. So anyone who died have a diagonal, line, which suggests that this gentleman or female is no longer surviving. Now, coming back to the case, so what we learned that here female is transmitting disease to the female, in the 3 successive generations. That is very clear. And how it is different from other diabetes. So if we make a DD of any diabetes running in a young person, you always think about either a genetic form of diabetes or monogenic diabetes like MODI. Now here what is interesting that only the mother is transmitting the disease to the children, and the female who is infected with the disease is further transmitting this disease to the so basically it is maternally inherited disease. That's very clear. And if you look in this pedigree chart, everyone, those who suffered from diabetes also suffered from the deafness problem, means impaired hearing. So if you actually look at this particular patient, one thing is clinching clearly the diagnosis that this is a female inherited diabetes, which is transmitted in 3 generations, which is associated with impaired hearing. So there is no further DD to diagnose this particular case, and that's why we stamped it as a maternally inherited diabetes with deafness, which we call MIDD. So that's the basic way to differentiate from other diabetes. Now, why it is not type 1 diabetes? That we need to really do a marker. So actually, when this case was shown to all of us, I had a discussion with Prabhat because patient's party was very poor. We could not, undergo different antibody testing like GAT65 or insulin antibody or islet cell antibody in this particular case because they were very poor. And we had a very clear-cut diagnosis that this is running in 3 families. So we thought that the entire, finance whatever. I mean, patient party did not contributed anything. Actually, the Prabhat paid all money from his own pocket for undergo a genetic testing. So we had only two things in our mind. Either it is a case of some kind of Modi, where actually we don't find any sensory neural deafness, or it could be a case of mitochondrial diabetes. So we put all the money for the genetic testing and we caught this case very early. So that's the story of this particular case.
Can I ask one question?
Yeah.
So generally, we don't take this much detailed history, family history, in a routine clinic when a routine patient comes to us with diabetes. So what are the clinical situations in which a detailed family history with this pedigree analysis is very much important?
Right. So this is what exactly I told Dr. Pratap, that see, once, if you get a young diabetic presenting with a DKA, you always tend to diagnose as a type 1 diabetes, and it should be treated in a type 1 as a type 1 diabetes to start with, to safeguard the patient first. Now, in this particular case, the problem was that the patient had, impaired hearing, and the patient also had a vision loss, and there was no reason to believe that what is the cause of the vision loss. So when this case was referred to the ophthalmologist, they diagnosed as a case of macular dystrophy in this particular patient, which was cause of the vision loss. I'm sure Prabhat will share after this slide. And then they referred to the ENT, what is the cause of this deafness. And after doing a pure tone odometry, we could stamp that this is a case of sensory neural deafness in a young, adult. And therefore, everything went towards something abnormal. And we started thinking that, is it something different which we rarely encounter with? And then we started asking the family member. And then when we went back, we could see, and as you can see, the pedigree basically pinpointed the diagnosis very much in favor of mitochondrial diabetes. So in summary, when you suspect a case of type 1 diabetes with something which is peculiar, like deafness or a vision problem, which is not exactly diagnosed because of diabetic retinopathy in general. He has got a diabetes for last 9 years, and there is nothing to define deafness in a young adult. So the clinching point towards mitochondrial diabetes was impaired hearing, to be very frank with you, because the impaired vision can happen because of several factors, because of uncontrolled diabetes and the changing blood sugar levels. You may have impaired vision, and you may have several differential diagnoses for the vision loss, temporary vision loss. But the permanent hearing loss was one clue, which basically pinpointed to go beyond type 1 diabetes or Modi to look at some other diagnosis.
I think fine, Dr. Prabhat, can you proceed?
Yes,
So
sir.
can I add one thing?
Yeah.
Yes.
Yeah. So very well explained, of course, by AK. But had it been optic atrophy, would have the diagnosis changed to DID mode?
Right.
Of course,
So
this is DID mode patients come much earlier.
Yeah.
In the
So
second
yeah,
decade, this is the
that
third
is
decade.
one of the DD, Sanjeev, for these kind of young onset diabetes. But the presentation which was there in a background of deafness, and then when we inquired about the family history, that was one of the differential diagnoses. So you are absolutely spot on in making one of the differential diagnoses. But however, presentations are a little different in DID mode compared to the mitochondrial diabetes. In fact, this case was also a little bit peculiar that actually they presented very early. The classical presentation of mitochondrial diabetes is in a later stage of life, classically in 3rd and 4th decade. There are cases presented on even 6th, 7th decade. But it depends upon, the heterogeneity of mutation. So in this particular case, they were severely infected because of mutation at the transfer RNA. And therefore, everyone in the family until 3, previous generation had, diabetes at younger age, and many of them died. So, that was peculiar point in this particular case, that everyone was infected at very young age, which is not classical of even a mitochondrial diabetes. But that was the case because it was confirmed.
Yeah, Dr. Prabhat, proceed.
Thank you, sir, for helping me. Yeah. So thus, on the basis of, as you all know, strong medical family history, especially maternal inheritance, hearing, and the vision impairment, we suspected MIDD, maternally inherited diabetes and deafness. As sir AK sir has already told, he was poor and he was refused for any investigation. Even he was not ready for the HUNC. So as I post this case on the CME India. So this was a boon for me and for the patient also. AK sir has advised me for the genetic analysis, and I advised patient A2G substitution, and it was turned out to be positive, and mutation was from A2G substitution at 3243. And this is the report of this patient. Yeah. 56%. This is very high heteroplasmy, and we know that phenotype presentation basically depend on the heteroplasmy levels. Usually such type of patients have low heteroplasmy from 10 to 20%, and depends from person to person. As this patient, the heteroplasmy very high, up to 56%. So in this patient, presentation is very earlier, very family strong history, and the very classical presentation in the early ages.
Dr. Prabhat,
Sure.
did you look for other things which are very much accompanied by this disease? That is, did you go for seeing the cardiomyopathy or the neuromuscular or psychiatric disorders or some macular dystrophy already you have detected? And what about the renal status? Because these things are also very important.
Yes, sir. For the further workup which was available in our college and our setup, I advised MRI, and in this we look for the cause of the what was the cause of the GTCS in this patient, but it was simple gyral swelling and it was a hypertense, and we also advised CSF analysis, and the lactate level was a little bit high, 56.4. As we can see in this slide, normal values are 10 to 22 milligram per deciliter, but her CSF lactate levels were very high, 56.4. Ophthalmic examination from our colleague, he suggested maculopathy. We also took the help of our ENT colleagues, and it was on pure tone audiometry. It was for the bilateral sensory loss, and especially for the high tones.
I will just stop here. Why did you go for this CSF analysis? What was the indication for that?
Sir, basically, when I took the help of one of my students who is associate professor in the AIMS neurology, basically, he suggested me, sir, go for the CSF lactate label. You should rule out MELAS,
Yeah, Dr. Salin sir, are you there? Dr. Salin sir, neurologist. Dr. Salin sir. So you please explain why this was indicated CSF analysis for lactate levels at this moment.
Yeah, presentation was also with the altered sensorium. So history of GTCS with altered sensorium, definitely MRI should be done, even if we get a decay. And second thing, lactate level high is another feature of a mitochondrial disease, which is a disorder of energy metabolism.
Yeah.
So lactate level gives the extra clue to us.
And Dr. Prabhat, what the antiepileptic drugs the patient was taking?
He was on this levetiracetam, sir, and this valproate.
Valproate.
Valproate he was taking. He was on the levetiracetam. Initially, since childhood, he was taking valproate, and for the last 2 or 3 years, as seizures were not controlled, so some physician or the coax was added levetiracetam. So levetiracetam was for last 2 years, and valproate was almost more than 10 years.
But when you diagnosed this case as MIDDM, then did you stop valproate or you continued it?
No, sir. We stopped it.
Yeah.
I'm discussing the next slides. Can I go ahead?
Yeah, go.
So this is the audiometry report. I'm not very expert in this report, but it was suggested by my colleague. It showed the bilateral sensory hearing loss, especially to the high tones. This is the report of fundus examination of this gentleman, and it was showing maculopathy. So, as we discussed in this CME group, as valproate can cause lactic acidosis, so we stopped valproate and we added clobazam. We try to add coenzyme Q as suggested by some studies and also in the group that it can delay the progression of hearing loss compared to the placebo. But because of poor affordability, we helped in initially for the 10-20 days, but because these salts are very costly, so he was not able to afford it. So he stopped after the 10 or 20 days.
So just 1 minute, Dr. Salim sir, why valproate is not given in such cases? What is the exact reason?
Valproate, there are two or three things. Valproate can cause lactic acidosis. Another thing, it affects the carnitine also. So energy, metabolism, and carnitine also play a role in the pathogenesis for mitochondrial disease. So the drugs, anti-diabetic drug, if we go by safety, based on levetiracetam and maybe clobazam. Other drugs, enzyme inducers, and they also be as far as possible avoided in these conditions. Mitochondrial disease.
Yeah, okay, proceed. Yeah, Dr. AK Singh, can you add anything here?
Yeah, so as Dr. Salim told you that there are certain anti-epileptic drugs. Remember, there are different variety of seizure. Even neurologists call them a mitochondrial seizures. There are certain drugs which needs to be stopped in people with a mitochondrial diseases, and this includes starting the valproate comes at the number 1. We are not supposed to use 3-4 anti-epileptic drugs in any patients having a mitochondrial disease. There are a wide spectrum mitochondrial disease. You cannot count. There are certain difficult names starting from this MIDD to MELAS to LOB. There are a number of you can't even pronunciate. There are a variety of syndromes associated with mitochondrial diseases. In these conditions, primarily because this involves central nervous system, these patients are very prone to develop seizures, and so there are certain anti-epileptic drugs that needs to be stopped. Sodium valproate is stopped here in this case is because of chance of having increased lactic acidosis. But please remember there are certain anti-epileptic drugs that actually deteriorates mitochondrial phosphorylation. For example, even phenytoin, carbamazepine. These drugs are not supposedly used in mitochondrial diseases causing convulsion. So there are limited number of anti-epileptic drugs that are safe in patients with epilepsy with a mitochondrial disease. And it's not only related to the anti-epileptic drug. Also, please remember for the diabetic perspective, and I'm sure we will be presenting later on, we need to stop those drugs which are prone to develop lactic acidosis, for example, metformin. Also need to remember there are certain drugs that needs to be completely forbidden in patients with mitochondrial disease. For example, the very commonly using aminoglycoside. We are not supposed to use aminoglycoside in patients with mitochondrial diseases. Even if I remember correctly, what you call the common antibiotics which we use for a staph.
I think linezolid as well as
Linezolid should be avoided.
Linezolid, and aminoglycoside and linezolid is not at all allowed in patients with mitochondria. So these are certain drugs which needs to be careful. For physician, I just thought to give a reminder of the drugs. This should be carefully used in people with mitochondrial disease.
How about statins? Statins.
Yeah, good one. So statin is also be careful about statins. Please remember that often these patients are suffering from cardiomyopathy. So because these involve mitochondria and the myocardium, so these patients also suffers from myocardial diseases. So in one hand, there is issues with the statin in terms of coenzyme Q, and myopathy induced by statin. These people are little prone to develop myopathy. But again, also we need to make a balance between these side effects versus the cardiovascular disease these patients are suffering from, like cardiomyopathy. So in one hand, statin might be useful in terms of preventing cardiovascular diseases, but in other hand, even the statin might be responsible for damage. So you have to make a balance whether patient needs a statin in these kinds. So that's a good suggestion.
Dr. AK Singh, one thing that after giving a big presentation like this with family history like this and with genetic test which revealed the diagnosis, so you are satisfied that this genetic test has already confirmed the diagnosis?
Of course. So otherwise we cannot make a diagnosis. So mitochondrial diabetes with deafness is a distinct entity, and it has to be confirmed through the genetic test. Otherwise, what can we diagnose where we're dealing with mitochondrial diabetes? It has to be confirmed.
Yeah, Dr. Prabhat, please proceed.
Yes, sir.
Can I ask one question to Shaleen?
Yeah.
Yeah.
So do these mitochondrial diseases, they present with only generalized tonic-clonic seizures, or a wide variety of seizures can occur as a result of mitochondrial disease? And when should you suspect, suppose a patient is having some other, whatever the other comorbidities or other conditions where you will think of mitochondrial disease as a diagnosis or as a culprit for seizures or epilepsy?
Mitochondrial disease neurology is very common. So I think most of the mitochondrial disease have a neurological manifestation. Most of the syndrome have neurological involvement. Typically, GTCS and the another syndrome is MRF, myoclonic epilepsy with red red fibers. So myoclonic seizures can be seen. And of course, if the patient has developed a brain damage, you may get even focal seizures. But classically, myoclonic seizures and GTCS, they are more common. And of course, there are other lot of neurological syndromes which can occur in patient of mitochondrial disease. So when do we suspect? Classically, there are certain classic syndromes. Like one is ophthalmoplegia, progressive external ophthalmoplegia, where patient has got progressive ophthalmoplegia at a younger age, 15 to 20 years. Second will be Kearns-Sayre syndrome, ophthalmoplegia with ataxia. There we suspect at a younger age. Third is this MRF, myoclonic epilepsy, and associated with that you get a myopathy. Other is MELAS. So mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. So patient develops stroke-like episodes. MRI is very typical. You get lesions on diffusion which disappear on follow-up, as they are believed to be due to hypoperfusion rather than ischemia. So non-vascular lesions which go away on follow-up on MR imaging may give a clue to the MELAS. And of course, associated systemic involvement, deafness, then vision loss, diabetes, and other systemic involvement, GI involvement can occur, neuropathy can occur, myopathy. So classical syndrome or patient with neurological heavy systemic disease, we suspect mitochondria.
Yeah. Dr. Prabhat.
Sir. At that time when I saw this patient first time, as he was not affordable, but in the last 6 months ago, I advised get 65 because he was not very, as his patient, this patient was suggested by someone, कि you have type 1 diabetes, तुम्हारी कभी भी जान जा सकती है. So from my own pocket again, I advised get 65 and it turned out to be negative. I have missed the report, otherwise I will post it. And at that time when we diagnosed the case as discussed by AK sir and the other persons on this group, I started glibenclamide, that is a dionyl 5 mg BD, and sitagliptin 100 mg daily. We stopped the metformin and glimepiride combination, and we started glibenclamide 5 mg BD and the sitagliptin BD daily 100 mg. Just 3 or 4 months ago, I also started imiglivin that I read somewhere in the one paper. The imiglivin works on the mitochondrial level, so it may help. So I started imiglivin along with the glibenclamide and the sitagliptin.
Again,
yeah. But after 3 weeks of starting imiglivin, he started episodes or recurrent episodes of hypoglycemia. For this, he needs to admit it in one in the hospital, Firozabad Medical College, and 2 times he admitted in my Medical College Agra. So we stopped this glibenclamide. So currently he's on imiglivin 1000 mg BD and the sitagliptin 100 mg daily. After 3 months of this, his HbA1c was 8.6. As I already stated, he is very poor, so he is unable to afford coenzyme Q10. And I'm also not, because I have to provide this imiglivin and the sitagliptin with the help of the pharma colleagues. But as I have no MR for especially this coenzyme Q10, so that's why I'm not able to provide him. But currently he's on imiglivin 1 mg BD and the sitagliptin 100 mg daily.
So you never started this metformin or insulin because your patient is not on control. HbA1c is still high. So, and how did you start this semaglutide? Is there any paper or any suggestions for that? And Dr. I think here we need the comment of Dr. AK Singh about the metformin and this new drug he has started. So, Dr. AK Singh.
Well, so we don't have any studies with imiglamin, but it was a little heroic attempt to add, because see, if you look at the mechanism of action of imiglamin, because they are the mitochondrial energy booster. So, and this is a mitochondrial disease. So, theoretically, this should be the drug of choice if it really works. So it wasn't a bad idea to start with, to add on imiglamin. As you can see, initially metformin is of course not recommended looking at the mitochondrial diabetes and chance of having lactic acidosis. This gentleman already had lactic acidosis in the past. Metformin was not the great choice to continue, and that's why it was stopped. Then glibenclamide was added. I mean, because of the cost. When it was not maintained, then sitagliptin was added. When it was not maintained, then imiglamin was added. Now patient landed with a hypoglycemia. So it's a fair decision to stop glibenclamide in this particular patient and continue with the sitagliptin and imiglamin. So we don't have any data, but then because imiglamin is a drug which works just opposite to how the mitochondrial diabetes happens, this should be beneficial. And to be very frank, that is very interesting to note that when the patient was simply taking sulfonylurea and sitagliptin, HbA1c wasn't controlled. The moment imiglamin was added, this gentleman landed in a hypoglycemia. So HbA1c will take time to come to the target, but the hypoglycemia episode after adding imiglamin does speaks volume about the energy boosting mitochondrial support with the imiglamin. So it's working in the direction how this drug was supposed to work. And I'm good to see, in fact, this is another way to present the continuation of this paper, that does imiglamin work in patients with mitochondrial disease? This is another area to look at. And if you really look at this particular case, I'm amazed to see that imiglamin did work. If someone is landing with a hypoglycemia, means it worked. So that's good news, but we need to document it.
Yeah. So, Dr. Sanjeev, do you have anything to add or comment?
Dr. AK already explained the benefit of imiglamin, but it's too early to say. We need some studies, as AK already told. But why this patient developed DK? And DK means patient has some insulin deficiency. So would not be giving a small dose of maybe at least basal insulin a bad idea? Because insulin patient definitely has some deficiency, though through mitochondrial route or whatever route. But he developed DK, and I would still be hesitant in not using insulin in this case.
Well, so yeah, so that's a fair point. Someone who had a history of DKA should be requiring, at least the basal supplementation. But look, even for past 1 year now, if I remember correctly, year has passed now, and this gentleman is not on insulin and never developed DKA further. Rather he landed with hypoglycemia. So if you look at the mechanism how mitochondrial diabetes cause beta cell dysfunction, ideally these patients might need insulin, in later part of time. So basically, the mitochondrial diabetes works through the secretory defect of beta cell. However, if you look at the literature, there are a number of cases which has been recognized as a purely insulin resistant variety of diabetes. Nevertheless, in this case, because this boy was admitted with DKA, theoretically a consideration of basal supplementation at least is justified. But then if someone is managed well on these tablets, there's no hard and fast recommendation. And look, even sulfonylurea is causing hypoglycemia. So are we comfortable adding even insulin in this case is, to look at. But then keep in mind that this patient actually will need insulin in later part of life. There is nothing denying. If you have got a mitochondrial diabetes, your beta cell will not work. You have got a secretory dysfunction and you will need insulin in later part of life.
One more reason, AK, is that the patient had worsening of his vision and deafness whenever his hyperglycemia was bad. That was mentioned in the history, I think. Was
yeah,
it?
so yeah, that
So
was
then-
yeah, I don't know, Sanjeev, what was the cause of that correction. Normally, if you look at the literature in mitochondrial diabetes, these blindness are permanent because this is a macular dystrophy which happens, means you cannot cure it. Now, in this case, perhaps this was in earlier stage of course, if someone develops dystrophy, that's the end stage of macular disease. This gentleman may have the initial stage of macular edema, which got, corrected after the, hyperglycemia was corrected. And I don't know whether a follow-up ophthalmoscopy was done. I would rather encourage Prabhat to, to undergo ophthalmoscopic examination of this young boy to look at what happened to macula now, and yet they need to show us whether it has been corrected or it is worsening now. So that was unexplained to me as well. But the theoretical possibility that because it was corrected after the rapid correction of blood sugar, perhaps it was in earlier stage of macular edema. If it had not had been treated, it would lead to a permanent macular damage and leading to blindness.
Yeah, Dr. Prabhat, we proceed.
Sir, regarding the insulin, one thing I want to add, as I asked him initially for the insulin level, as at that time I also don't know what is the diagnosis of the patient, as patient presented DK. So of course I initially suggested it was maybe because of the history of the pancreatitis somewhere, or somewhere it was because of the type 1 diabetes. As I asked him for the insulin, his father just ran away from my clinic. कि जब इंसुलिन नहीं लगवाऊंगा, इसकी माँ भी इंसुलिन लगवाया था, वो चली गई, और मेरी बेटी भी चली गई, और इसका मामा जैसे इंसुलिन लगा वो भी चला गया. तो सब मैं इंसुलिन तो किसी भाव नहीं लगाऊंगा, लड़का मेरा बच्चे चाहे मरे. So this was the biggest challenge for particularly case. So in the nutshell, I want to summarize here. MIDD is a rare form of the monogenic diabetes that results in most cases from A to G mutation, especially 3243 mitochondrial DNA. There are some also rare mutation is there, and the mutation is variable, and that's because it depends on the heteroplasmy ranging from mild to severe phenotypes. And usually diabetes is accompanied by sensory deafness, cardiomyopathy, neuromuscular disorders, psychiatric disorders, macular dystrophy, and in some sets of the patient develops renal failure also. And as you can see in this picture, some patients may have hypogonadism, some patients may have short stature, maculopathy is there. Proximal myopathy is also reported in some cases, and the left atrial hypertrophy is arrhythmia can be seen in some sets of the diabetes, this MIDD. So usually in the literature it is said MIDD is not seen with the DK, but in literature we also found that 8% of the diabetic of MIDD present with the DK. It is also reported in the literature, and also our patient also presented with the DK. Next, in the follow-up, I also advise GAT antibodies, and this patient usually don't have GAT bodies, as like in especially in our patient. Hearing loss in MIDD is sensorineural and is cochlear origin rather than the cranial nerve origin, as well explained by the audiometry. Some patients of MIDD also have the associated features of the MELAS. MELAS, as Shah sir also mentioned, mitochondrial encephalopathies, lactic acidosis, some features of the stroke-like episodes. Some psychiatric disorders are also seen in MIDD patients, especially depression, schizophrenia. Some variety of phobias also there explained in literature. Most common ophthalmic feature is the macular retinal dystrophy. Myopathy is also reported with the MIDD, especially the proximal limb myopathy. And one thing is very peculiar, exercise-induced muscular cramps or weakness is also reported. Some patients, these type of patients have very high prevalence of the ESRD. Renal biopsy sometimes prove features of the diabetic nephropathy, but the most prevalent finding is the FSGS. We advise patients for the USCR and the ultrasound. It was normal. Ultrasound was absolute normal. Kidney size was normal. There was USCR was normal. Normal uterine microscopy normal. Kidney level was normal. So there was no features of the renal dysfunction, especially in our patients. And few of the patients, especially women, present with the proteinuria, and this may be the early presentation. Premature deaths can be there of the cardiac causes. Young adults, like rapid progression to symptomatic renal heart failure over 4 to 12 months has been described also. Left ventricular hypertrophy, cardiac arterial neuropathy, atrial fibrillations, sometimes frequent extrasystole are more commonly seen in. Most common endocrine manifestation of MIDD is short stature, but our patient height was okay.
So India won and Kohli made a century on the last ball. 2 runs was required. He made a 6. Made century and India won.
Yes. Congratulations, everyone.
Congratulations,
Yeah.
everyone.
May I ask one question? What's the cause of death at such young age in most of these cases? Is there any role of QT prolongation?
Yeah, this
Yes,
is
sir.
possible. There are, many, reasons behind the death. We don't have any proof. So theoretically, this might have happened because of, uncontrolled diabetes, decay, acidosis. This could have happened because of QT interval prolongation. It could have happened with arrhythmia due to cardiomyopathy. So there are several explanations. Someone in the family might have developed a stroke in early childhood. Because we don't have any documentation from the 3 generations back, we exactly don't know what was the cause of death in the family. But these are the likely possibilities.
About any QT
Dr. Pratap,
prolongation in this case?
Pratap, I think WPW syndrome has also been reported. WPW syndrome, number 1. My question is regarding the cognitive impairment. Do you come across, Dr. Prabha? Cognitive impairment.
No, sir. Patient was absolute fine, whereas blood sugar is controlled. He almost very intelligent guy, working in a petrol pump along with his father, and he's very well in IQ. In terms of IQ, he's not read. He's read only till 10th, I think. 10th, 11th, उसने किया उसके बाद otherwise he's quite intelligent.
Another question is, there is no evidence of diabetic retinopathy despite the duration of diabetes. Am I right?
Yes, sir.
Dr. Salin wants to say something. Please give him a...
Yes, sir. Very interesting case, and relatively odd, uncommon manifestation of a mitochondrial disease. Just one comment, that mitochondrial disease is due to energy dysfunction. So in neurology, we are used to seeing that encephalopathy or stroke-like episodes are associated with fever or stress in any systemic stress, and they tend to improve. I'm not sure about this vision and the deafness, but this type of manifestation mitochondrial disease is due to energy. There may be some role of that also.
Yeah, so Dr. Prabhat, can you just stop sharing the screen so we can have some discussion now? 5 minutes more left.
Yes, sir.
Yeah, you just go and yeah. So I think very well presented, and I think most of points already we have discussed, and Dr. Avdesh has beautifully explained from the very beginning, from the diagnosis, the history, many the lacunae in history, and even the pedigree chart which has been shown. So I think we have only 4 minutes, so I think one by one. First, Dr. Sanjeev Phatak, what is your first conclusion or your comments, your take-home message for our viewers?
First and foremost, congratulations to Dr. Prabhat Agrawal, Dr. A.K. Singh, and the whole team who worked for this case, suspected that this can be maternally inherited diabetes. So I must congratulate all of you. Second, this is a take-home message for all of us that any patient who comes to you with diabetes, deafness, and ophthalmic problem, 2 diagnoses should be kept in mind. One is, of course, lead mode, and the second is this maternal inherited. So all the diabetes are not type 1 or type 2. We should suspect some other genetic forms of diabetes or monogenic diabetes, especially in patients with strong family history on maternal side.
Dr. Sanjeev, suppose such patients comes to you, most of initial will start metformin. So it is very difficult that if we have not started metformin, in such case, this was really beautiful, but otherwise, in most of such conditions, we go for metformin, and what happens, in every case, it happens that they will end up to the lactic acidosis. Is it so?
I think lactic acidosis is not that common. It's an extremely rare. So even if someone had used it, I don't think metformin would have caused lactic acidosis. Correct me if I'm wrong. But whenever you are having any doubt about the diagnosis of diabetes, it is better and safer to start with insulin, and then you can take your time for the further diagnostic testing. That's what I generally do.
Dr. Your comment.
I just wanted to add on this comment. Well, so as you said that whether it is a crime to start metformin, unless we diagnose that this is not a mitochondrial diabetes. No, answer is absolutely fine. Even if you continue on metformin, that's not a crime. Remember, metformin-induced lactic acidosis is a very, very rare phenomena. The exact prevalence of MALA, metformin-associated lactic acidosis, is 10 in 100,000 people. Means in 1 lakh patient on metformin, 10% develops lactic acidosis if the person receiving metformin has got a kidney disease. So that's the prevalence in patients with CKD. In patients without CKD, even this prevalence would be 1 in 10 lakhs. So therefore, even if you have started metformin in patients with mitochondrial diabetes, it is not a crime. Of course, once you have confirmed the diagnosis, preferably you would not like to continue with the drug. So that's the first point. Why this case is rare and important, and it would be surely cited in future, that we didn't find a single case of mitochondrial diabetes reported in literature that was admitted with a diabetic ketoacidosis. So they do have a mitochondrial dysfunction and beta cell dysfunction because of mitochondrial dysfunction. See exactly what happens in mitochondrial diabetes. Your mitochondria is not working well. So your mitochondria in the beta cell is not able to put the product of glycolysis into the Krebs cycle. So you are not producing ATP in mitochondria. And therefore, if you are not producing ATP in beta cell, you are not able to release insulin. Very simple. Now, these patients are having a secretory dysfunction, not absolute insulin deficiency. So therefore, they should not develop DKA. As you can see in this case, for past 1 year or so without insulin, this gentleman is not developing DKA. In this case, he was landed with DKA. That was the rarest presentation. We didn't find even a single case presented with DKA. So that was one unique case from our part of the world.
And your final message for our viewers?
My advice and suggestion would be that nowadays, if I was just searching into the literature before I joined, that how many new cases has been added into the into the literature. We did find that very recently, in past 6 months, when we submitted this paper nearly 8-10 months back, at that point of time, we had a limited number of reported cases of mitochondrial diabetes. In past 6 months, I could see there are another 30 patients who have been reported in the literature. This speaks volume that perhaps we are in the era where we are very careful in diagnosing different type of diabetes. Now we have got because of wider availability of genomics, genetic analysis, perhaps we are finding a lot of these cases, especially in diabetes in young. And so therefore, my message is that if you find anyone, young people with diabetes, with a family history of diabetes, don't stick your diagnosis only to the Modi, or young onset type 2 diabetes. If you find someone who is a lean, a young diabetic, do suspect about mitochondrial diabetes. That's the first difference between Modi, young onset type 2 diabetes, and mitochondrial diabetes. They are leaner, they are cachexic like a type 1 diabetes, but they are not type 1 diabetes. So they are somewhere between Modi and type 1 diabetes in terms of their phenotypical appearance. So if you find young type 2 diabetes, if they are lean, requiring insulin, but they are antibody negative, and there is a family history of diabetes in 3 generations, do suspect that it could be a mitochondrial diabetes if there is a family history, in particular in mother. So that's the the simple message for this case.
Yeah, Dr. Stalin sir, your last comment about valproate. Suppose someone started valproate, so what will happen? All cases will end up again for the MELA.
Valproate is to be avoided as far as possible. It's not that all patients if you use valproate should end up with MELAs or other thing, but definitely valproate affects the energy metabolism, carnitine also, so should be avoided.
Yeah.
Otherwise, I thought it was a very interesting case, and it was my pleasure to be part of this.
Yeah. So, Dr. Pratap Jethwani, your final comments with a vote of thanks.
So I think we have learned the importance of family history in diabetes, particularly in young onset diabetes. Always take a look at very detailed family history that will give you a lot of clue about what is there. And then you can suspect other forms of diabetes rather than our conventional approach of type 1, type 2 or MODY. And always try to look out for the abnormalities in the patient in the form of a deafness or vision, whether they are having any other problem or not. Even in the middle age, if somebody is having new onset diabetes with deafness, I think one should keep in mind and take detailed family history to suspect this kind of diabetes where the treatment differs very much from the type 2 diabetes. With that, I thank Dr. A.K. Singh, Dr. Sanjeev Pathak and Dr. Shalin Shah for highlighting us about this mitochondrial diabetes or maternally inherited diabetes, and Dr. Prabhat Agrawal for a beautiful case, for excellent publication, and for making people aware that even mitochondrial diabetes can present with DK. So even people who are presenting with DK, if they are having other abnormalities or very positive, strong family positive history with deafness or other thing, you can think of mitochondrial diabetes also. And thank you, Dr. N.K. Singh, for inviting all of this and making us all together for this interesting Rssdi case files. We will again meet next month, probably after Diwali, again on either Thursday or Friday evening, 8:30 to 9:30, with another interesting case related to diabetes or diabetes complications. With that, I thank everyone and good night.
Last comment will be Dr. A.K. Singh has given such a wonderful inputs today that we have so much things have become very crystal clear. So I think the message is quite clear, and with all our panelists and with you, I think we will end up here. So thank you very much. Good night.
Thank you, everyone.
Good night.
Good night.
Good night.
Thank you, sir.
Thank you.
Thank you.